Hello everyone, my name is Michael Hartung. I am an abdominal radiologist from the University of Wisconsin-Madison, and I am presenting a rapid review of renal pathology. So we're going to kick it off with some humble beginnings and start with just talking about renal stones, which commonly present with flank pain and hematuria. And let's get some terminology out of the way. So talking about the locations that you might find the stones along the genitourinary tract, starting with calyceal stones, pelvic stones, ureteropelvic junction stones, which is right here. You'll have stones along the course of the ureter or ureteric stones. A common location to find stones is at the ureterovesical junction here. And after they pass into the urinary bladder, you can sometimes see them layering in the bladder or forming primarily within the urinary bladder due to stasis. And let's kick it off with our first case here. So we'll scroll down a little bit, and one of the things when you're looking at this axial view of both kidneys or the coronal view of both kidneys, you get a sense of the symmetry or asymmetry of the kidneys. And so one of the major observations here is that there is hydronephrosis of the right kidney and a normal left kidney. And also there is something called a delayed nephrogram, which is due to increased hydrostatic pressures of the obstructed kidney. There's decreased perfusion of that kidney, and therefore we're seeing less contrast enhancement. So that's an important finding that you'll find with obstruction, and something that tells you to make sure you're carefully running that whole ureter. And so let's follow that right ureter all the way down to the urinary bladder here, and we find this stone just 1 or 2 centimeters above the ureterovesical junction here. So just before it starts to kind of pass right into the urinary bladder. So here we go, distal obstructive stone resulting in hydronephrosis and delayed nephrogram. So the major findings you're looking for when you're dealing with renal obstruction due to stones or potentially tumor as an enlarged kidney with hydronephrosis. You'll see a dilated ureter, that delayed nephrogram, where sometimes you'll even see that you'll still have that differentiation between the inner medulla and the outer cortex compared to the normal other side. And here's that look on the coronal view where we get a better sense of the asymmetry of that kidney due to a proximal obstructive stone. One of the things to make sure that you've kind of thought about in your own practice is that when you're encountering a CT urogram, which is going to be one of the most common studies tailored for looking at the GU tract and the kidneys, is how you're going to be approaching each series efficiently. And so I do encourage you to consider a checklist approach. And so for the non-contrast series, that's the major utility of that is to look for renal stones. In the nephrographic phase, you're not only looking at the kidneys and looking for renal masses or abnormal enhancement, but actually running the entire collecting system, looking for abnormal thickening or enhancement of the wall through the ureters and into the urinary bladder as well. And the excretory phase is primarily for looking at filling defects in the collecting system, ureters and bladders, and you'll need to window that out a little bit sometimes to see through that bright contrast. All right, let's look at another case here. So as I'm scrolling down, we see the delayed right nephrogram compared to the really bright left kidney. And we also see this kind of complex cystic structure here. And let's scroll a little bit farther here. And there we have a big bulky stone right at the pelvo-ureteral junction, which is resulting in obstruction of that kidney and also complicated by formation of an abscess. So being aware of the appearance of a renal abscess, which can be large and multilobulated like this, and also kind of have smaller areas here on the lower pole, which look like they might be forming like smaller coalescing abscesses as well. And so the big thing to know for this is that somebody needs to have a phone call and consider urgent decompression of this kidney due to risk of sepsis and loss of the kidney. All right, let's look at another case here. All right, so this might be a familiar picture to you. We have this big branching stone that is involving the renal pelvis, and then kind of having little gaps as it extends out in some areas to the calyces, but big bulky stones extending out to the calyces. Loss of cortical volume with really impressive kind of low attenuation material throughout the kidneys. So this is a very characteristic appearance of a chronically obstructed and infected kidney, and this is xanthogranulomatous pyelonephritis. All right, so now we're going to pivot on to the next topic, which is talking about renal infection and mimics. So not necessarily related to stone disease. We're moving past stone disease, and we're going to touch on some other sources of infection and also some important mimics to be aware of. All right, so for our first case here, and the idea with a lot of these cases is to build on them sequentially. So we're going to start with kind of a basic or foundational theme and then view some complicated forms of it or some important mimics of those disease patterns. So, all right, so it seems like right renal pathology is the theme of the first couple cases, and here we have delayed right nephrogram, or kind of globally hypoenhancing an enlarged right kidney. There is really impressive urothelial thickening and enhancement compared to the normal left side, and also some subtle areas of striations where the cortex is hypoenhancing. And I think that can be a little bit hard to see on axial sometimes. Sometimes you can pick it up a little bit better on coronal, and I'll show the value of using liver window to look at those striations. So, but this is just a basic case of uncomplicated pyelonephritis. And here we go. Liver windows can help. So let's take a look at this patient here who has probably had infection on the right side where the right kidney is quite atrophic, and then the left kidney looks like it's acutely involved. And so we have some of those areas of cortical hypoenhancement. I don't know if you're catching them as I scroll through, but like right here, for example, you can see that. And let's see the effect of using liver windows and how that might jump out a little bit more. And there we go. So those striations really kind of punch out and stick out a bit more using liver windows. So I think don't just think of liver windows as for the liver. Think of them for any solid organ when you're looking at differential enhancement. It can really help to focus your grayscale values on that kind of narrow soft tissue range, looking for subtle differences in enhancement or potentially masses. So really helpful to have liver windows as part of your arsenal when reviewing the kidneys. All right, so here we have, again, that picture where the left kidney looks pretty atrophic. There's some multifocal cortical scarring and volume loss, so it does suggest that there's been prior either vascular insult or infection of that kidney. And here we have some abnormal areas in the right kidney as well. Let's take a look at the coronal images and see what those look like. Okay, so not only do we have some areas of hypoenhancement kind of globally within the cortex, but now we have centrally some kind of little smaller collections forming. So this is kind of moving a step beyond just simple uncomplicated pyelonephritis, and I want you to be aware of this disease pattern. This is uncomplicated pyelonephritis with microabscess formation. And the other thing as a bonus, if you had wandering eyes during this case, was to see that the spleen is gone and there are multiple small splenules in the left upper quadrant. And also some other splenules kind of throughout the upper abdomen and into the peritoneum as well. So you got all these little splenules all over. So just kind of a fun little bonus to that case. All right, next case here. All right, so things are getting a little bit worse now. We're seeing more advanced and more complicated versions of pyelonephritis. So notice how those smaller microabscesses that we were talking about in the last case now we're seeing kind of the next level presentation of that, where we're seeing larger coalescing abscesses forming here. And then down below here in the lower pole, it's even kind of burst out through the cortex into the subcapsular space and indenting that a little bit as well. And then don't forget to look at both sides, and we have a little bit of kind of pyelonephritis on the right kidney as well. So this is a much more severe advanced case. And we also have a little bonus pickup here in the left renal vein. There's a small linear area of non-occlusive thrombus. Okay, so we have pyelonephritis with microabscesses for that case. All right, for this next case, we have yet another presentation of pyelonephritis where we have relatively kind of a large area of hypoenhancement of the right renal cortex, and we're seeing larger, more coalescing abscesses. And I'm really just kind of showing these variations so that you're aware of the variety of appearance that renal abscesses will have, and also just so that you're not expecting to see necessarily a large or well-organized collection, but they're often these smaller microabscesses, which then coalesce into these larger abscesses. So here we have just another case of complicated pyelonephritis with multifocal coalescing abscesses, and you're also seeing that supporting finding of urothelial thickening and enhancement. All right, and so for this case, we're seeing, again, left renal kind of relative enlargement of the kidney, relative hypoenhancement of the kidney, and we're also seeing multiple abscesses within the left kidney, with an important variation in this case where we have a combination of these microabscesses which have formed within the kind of upper and interpolar cortex, and then this larger collection in the lower pole. And so the main thing here is to not mistake this larger collection for a cyst. This is actually an abscess which is ruptured into the kind of inferior subcapsular, kind of through the capsule, into the inferior kind of pararenal space. And we're also seeing that some thickening and enhancement of the right ureter with some dilation as well. So kind of that spectrum of the formation of abscesses, where we went from microabscesses to coalescing to now kind of rupturing through the cortex and outside the kidney. All right, and so this patient is giving us yet another variation of cysts and abscesses. So we have a background of microcystic renal disease related to the use of a medication. See if you can guess what that medication might be as I'm presenting here. So, and we have a background of multiple, mostly small cysts, but also some kind of 1 centimeter or so size cysts. But then there's this larger one here in the left interpolar kidney. That looks a little more complex with an enhancing border, and also this collection here. So we not only have a background of microcystic renal disease related to lithium use, but we also have formed 2 abscesses within that left kidney. So kind of giving you a sense of that variation where you're seeing a thick wall with some increased enhancement relative to the simple cysts that are unrelated to acute infection. So just again, some of the major findings that we covered here. When you're talking about infection, you're looking for enlargement and abnormal enhancement, generally hypoenhancement of the kidney, urothelial thickening and increased enhancement, stranding and fluid surrounding the kidney, although that can be relatively a not specific finding, also seen in the setting of obstruction, and the all-important striated nephrogram, which are areas of cortical hypoenhancement that are often best seen on the coronal images, as you can compare most of the kidneys side by side, and then flipping liver windows on will really increase your confidence. And then, maybe probably most of us would overlook the involvement of the left kidney, but here we can more confidently see that that left kidney is also infected using liver windows. And of course, be aware of abscess formation, which can start as microabscesses and form larger collections, which can even burst outside the kidney. And then be aware of stone formation that can be complicated by infection and require urgent intervention. All right. Let's keep going ahead with some more cases here. And here we're finding on our first couple slices that there's air where there shouldn't be air. There's air in the lower mediastinum here, surrounding the esophagus, in the upper abdomen, and really dramatic involvement of that right kidney. This is a diabetic patient. And not much of a mystery of this diagnosis here. We can just scroll through the rest of it. There's even some air in the urinary bladder that's gone down through the collecting system from that infected kidney. So this is an example of emphysematous pyelonephritis, and this severe degree of involvement would indicate urgent surgical resection of that kidney. All right, so we've really covered a lot of important cases related to infection, and as I'm just going to show you this case here as an important variation to keep in mind. You're probably thinking, okay, I feel like I've seen enough infected kidneys. Can we move on to something else? Well, this is not an infected kidney, and so that's what makes this case such an important case to keep in mind. So let's kind of get a sense of what's going on. This left kidney looks like it is, relatively hypoenhancing. We have a delayed left nephrogram. There are these kind of cystic spaces within the, mostly within the medulla. Makes you wonder if there's some abscess formation, although they kind of look like they're branching out like calyces, but this is kind of a bit, smudgier than typical hydro. And then we have some kind of almost isolated islands of dilated calyces here. So really kind of an interesting case. But then what's going on with this renal pelvis? So let's take another look at that on axial and see if we can get to the bottom of this case. So that renal pelvis has this kind of abnormal infiltrative look. And when you start to try to sort out, okay, well, that doesn't look quite normal. Let me see if I can follow the ureter. Well, that's kind of hard. The ureter's really got a lot of thickening and enhancement surrounding it. Okay, what about the renal vasculature, which can be an important item to add to your checklist for a lot of these cases. And let's take a look at that left renal vein, which heads towards the renal hilum, but then just kind of tapers off and gets lost in that soft tissue thickening. So we don't see that normal, typical branching of the renal vein. And so there's something going on here. And so what's our differential? Well, one of the important items to add to your differential when, maybe you think at first it looks like infection, but it's not infection, is to consider tumor. And this indeed is an infiltrative type of tumor. This is a infiltrative muscular invasive urothelial carcinoma that, now kind of knowing that in retrospect, you can imagine, okay, well, there's an infiltrative component of soft tissue surrounding much of the kidney, invading into that hilum, narrowing the vasculature, and also causing some areas of calyceal obstruction, and would account for that kind of infiltrated soft tissue appearance of that upper pole. So really a difficult case, but important mimic to keep in mind. All right, so here we have another mimic, left kidney. Much of the left kidney is hypoenhancing or perhaps not even enhancing at all. And then we're kind of just also thinking, what are the risk factors, right? Well, really severe atherosclerosis of the abdominal aorta with a little aneurysm there. And then trying our best on this portal venous phase to look for the renal arteries. Well, here you go. Here's the left renal artery. Looks like it's basically completely occluded. And so this is a case of renal infarct. And here's a patient who doesn't have underlying atherosclerosis, but does have another risk factor, which is a known diagnosis of antiphospholipid syndrome. And another example of segmental with less severe involvement. Excuse the jumping slide here. Just kind of more segmental upper polar involvement of a renal infarct. So just another example of renal infarct as a mimic for infection. And this is a patient presenting with trauma. As you can see, there's multiple areas of hemorrhage and small areas of bleeding within the spleen with hemoperitoneum and some other injuries of the adrenal glands. But we're here to focus on the kidneys, so let's stay focused on that left kidney. Okay, so much of that left kidney looks like it's completely infarcted. There's some other kind of striated areas of infarction as well. And this is an important complication of trauma to keep in mind. Let's take a look at the renal artery. So that renal artery comes out here, and even though this is just a portal venous phase, we can see that it kind of almost looks like it abruptly cuts off. Maybe there's a little bit of branching to that upper pole, but not much at all. And so this is an important mechanism of trauma, which is a renal artery pedicle stretch injury, often due to rapid deceleration in the setting of motor vehicle accident, and that can cause stretching. The kidney can basically move and have a shear injury along its vascular pedicle, which stays relatively fixed, and that can cause dissection and tearing of the renal artery and infarction. So this is a renal artery pedicle stretch injury, and I want to give you a sense of what this looked like 1 week later, which was that more classic renal infarction with that capsular enhancement. So finally, what we learned in boards. There's renal capsular enhancement for an infarction case. So I thought that made for a satisfying follow-up. And obviously, in the long term, what are you expecting to happen to this kidney? Well, here we go. 1 year later, we have the long term. And there it is, severely atrophic left kidney and some enlargement of the right kidney to compensate. Now we're ready to move on to our next topic, which is primary tumors. And some basic concepts to keep in mind. When you have tumor which is primarily growing outside of the kidney, it's called exophytic. And when it's growing into the kidney, it is endophytic. And here we have a nice side-by-side comparison of a renal cyst versus a renal mass or renal cell carcinoma here. And here's an example of an interpolar, left interpolar renal cell carcinoma. And just one of the things to keep in mind is how similar that heterogeneous enhancement pattern can be to the cortex and medulla, especially when you don't have that uniform enhancement kind of in the later nephrographic phase. And so it can be really easy to ignore these tumors, or to overlook these tumors rather, especially if they're mostly endophytic. Another concept to keep in mind, I'll illustrate this with a couple of the cases later, is that when you're dealing with an infiltrative renal cell carcinoma, a couple of the major features you're going to look for are not only the presence of infiltrative tumor, which can also be seen with urothelial carcinoma, but also you'll usually see a discrete exophytic rounded mass, and a major feature of those infiltrative tumors for renal cell carcinoma is tumor thrombus of the renal vein, and that's not a common feature of urothelial carcinoma. And so here we have an example of infiltrative tumor within the left kidney, and then that tumor thrombus here, and another example of infiltrative tumor within the kidney, that larger exophytic mass, and extensive tumor thrombus here, which is essentially growing. It almost looks like it's extending directly into the IVC from an extensive involvement of the renal vein as well. All right, so here's our first case. And here we have that example of that infiltrative tumor involving the left kidney. So not only do we have, and I think this shows fairly well in coronal here. Yeah, so not only do we have that diffuse involvement of that left kidney, and so you're kind of saying, oh, it's keeping that reniform shape. How could that be urothelial carcinoma? Well, you have this huge, bulky, exophytic, rounded component, which is much more typical, or kind of distinguishing feature for renal cell carcinoma. And we have that extensive tumor thrombus, which is probably seen a little bit easier on the axial image here, growing from the renal pelvis and then into the retroaortic course of that renal vein. Okay, so for this case, we have another variation of renal cell carcinoma with tumor thrombus. However, we're breaking the rules a little bit because the primary tumor is rather infiltrative appearing and doesn't really have that discrete mass that I talked about earlier. But we do have a common feature of infiltrative renal cell carcinoma, which is this tumor thrombus. And not only do we have an anterior branch of that left renal vein, which is full of thrombus, but we have this retroaortic, or we have basically a circumaortic left renal vein with a little bit of tumor thrombus extending into the IVC here. And here's what it looks like on coronal images. And then if you look carefully, we not only have that tumor thrombus involvement of the renal vein, but we also have involvement of the gonadal vein as well. All right, so this next case starts off, I don't know if you saw that on the first slide, but with a little bit of acute pulmonary embolus. And we don't have to scroll far to wonder why. There is a massive right renal cell carcinoma. And let's take a look at that. So we have this really bulky, extensive infiltrative tumor here. We can see that impressively enhancing tumor extending along that short right renal vein with a mixture of enhancing tumor thrombus and then some bland thrombus here extending up into the IVC. And then there's also this larger exophytic component of the mass, which is a distinguishing feature of infiltrative renal cell carcinoma. In addition to that, we have some unusual findings in the pelvis. I don't know if you were distracted by them or not, but here they are. So the urinary bladder is displaced by this big, strange-looking nodal mass. And then actually on our way down, there's this bulkier than expected retroperitoneal adenopathy, which wouldn't really commonly be seen even in the setting of a large renal cell carcinoma. We might, we have a couple of these hilar lymph nodes, which, down here and maybe kind of along the periaortic region immediately adjacent to the tumor, but heading inferiorly, seeing these bulky lymph nodes is not really a typical feature of renal cell carcinoma. And then we see several more enlarged lymph nodes, and we find that big nodal cluster in the pelvis with this fatty proliferation surrounding it, and then this one here that's maybe enhancing a little bit more with some calcification. So definitely seems like there's two processes going on. So when we read this, we recommended biopsy of the mass and also biopsy of these lymph nodes because we felt like there was probably a lymphoproliferative process going on. And this turned out to be renal cell carcinoma and then Castleman disease, which is a non-neoplastic lymphoid hyperplasia. Okay, so this is just more something for you to be aware of after treatment for renal cell carcinoma. So this patient had a right nephrectomy for renal cell carcinoma and then had multifocal disease. So the left kidney was treated by thermal ablation. So you can see these ablation defects, which is kind of a common post-treatment appearance, which are being monitored. And as we scroll down to the urinary bladder, we see a fat fluid level layering anteriorly. And this is commonly seen after renal ablation. This is called chyluria and is related to lymphatic disruption and leakage of chyle into the urinary system. And we'll just, it's benign, an incidental finding, and just what you'll see is that fat fluid level in the urinary bladder. All right, so on to our next case. This is a little bit of a cautionary tale, just this, if all you have is portal venous phase, to really be cautious about what you're seeing here in the renal pelvis, but there's some thickening and enhancement of the renal pelvis there, maybe with a little bit of calyceal dilation to draw our attention to that kidney, but that is tough. So we see that those dilated calyces and then that enhancing urothelial tumor, and then maybe you're seeing it a little bit better there, but we have those branching infundibula heading to the renal pelvis and that enhancing tumor there. Well, fortunately, we did have a delayed phase in this case, which nicely shows that nodular tumor as multiple filling defects. So I think this case does show the nice complementary role of looking at the nephrographic phase for abnormal enhancement and also using the excretory phase to confirm the presence of filling defects and properly raise the concern of tumor, which was confirmed in this case. All right, on to our next case here. And so here we're seeing this somewhat expanded hypoenhancing appearance of much of the left upper renal pole. And, one of the first things I do when I'm problem solving the kidneys is I pull up coronals because I think you just get a lot more information. And here we're seeing, wow, that's definitely like a lot more mass-like than I think we were first led to think based on that like gradual tapering on the axial images. Here we have this bulbous oval mass involving the interpolar and upper pole of that left kidney, and also similar appearance as that primary tumor or presumed primary tumor involving that left adrenal gland as well. So we have infiltration of the adrenal gland and a couple of periaortic lymph nodes, which are enlarged and abnormal as well. And so the big thing to be aware of in this kind of case is to, kind of be thinking of your mental checklist. This is not an infarct. This does not look like infection. This is infiltrative tumor, and this is a urothelial carcinoma, which was confirmed with biopsy. Okay, so now we're going to talk about some other tumors or tumor-like conditions. And here we are in our first case. And so we're focusing our review on that left kidney, which has splaying of the hilum with which is predominantly a fatty-looking mass. Let's look at that on coronal. Here we go. So yeah, some splaying of that left renal hilum. No really, it's not really like an aggressive appearing process in that there's no renal obstruction. But there is an important finding here that might be catching your attention. Look at that left renal vein. So that fatty mass with a little bit of vasculature in it is typical for an angiomyolipoma, but this one has an important variation in that it has grown into the left renal vein and caused some partial occlusion of that vein and extended all the way into the intrahepatic segment of the IVC. And so there you go, that upper margin's right there. All right, so here's our lay of the land. We have this left kidney has this strange looking soft tissue infiltration of the renal pelvis, which, maybe at first glance you're thinking, wow, that looks like urothelial carcinoma. Well, we can expand our differential a little bit beyond it, because now we're dealing with not only this mass, but we have these kind of strandy soft tissue masses in the retroperitoneum as well below the kidneys. And this is a restaging examination, and this patient has, if you can see on the without the bone windows, that the bones and the mineralization doesn't quite look normal. And so this is a multiple myeloma restaging with some new retroperitoneal and pararenal masses. And these are plasmacytomas. So we have pararenal plasmacytoma, which has resulted in this infiltrative soft tissue mass. And notice how it's resulted in some dilation, but not really a dramatic obstruction, and also some other retroperitoneal manifestations. So this next case is starting off with a small pericardial effusion. And this really bulky mass involving the left kidney and retroperitoneum. And there's also a mass of the right kidney. So we have two separate processes going on, even though it's nice to find a unifying diagnosis. There's actually two going on. So we have this typical appearance of a renal cell carcinoma of the right kidney, and then a very atypical appearance of a mass that's involving portions of the left kidney. Looks like it's displacing the kidney inferiorly. It's hard to tell if there's kind of invasion into the kidney with some kind of loss of that cortex of that upper pole on some of the slices. And it looks like it's primarily arising from the retroperitoneum and probably pushing and rotating that kidney down. So diagnostically, there's not much more to be done besides ultrasound or CT-guided biopsy, and that's what was done in this case. And we diagnosed a retroperitoneal leiomyosarcoma and then also a renal cell carcinoma on the right side. And continuing on with another example of a retroperitoneal tumor. Here we have displacement of the right kidney anteriorly, and then that kind of wrapping of that renal cortex around portions of the mass, indicating that it's actually arising from the kidney rather than just displacing it. And here we did an MRI, which basically shows, as you might have guessed, the MRI version of the CT findings, but still kind of interesting images to look at. And again, this just required biopsy. We made the key observations that it looks like it's arising from the kidney based on that kind of clawed-like appearance of the lower pole. And ultrasound-guided biopsy was performed, which found a dedifferentiated pararenal liposarcoma. All right, and so for this case, we have a more typical fatty containing retroperitoneal mass, which is quite massive in its size and displacing the left kidney into the pelvis. And so these imaging features are typical for a retroperitoneal liposarcoma. And one of the keys to forming your differential for different masses, although this one's not, a particular mystery, is to consider where the mass is arising from. And when you're dealing with large masses like this, one of the important things to do is to look at what structures are displaced. So in this case, we have look at the pancreas tail, the body and tail kind of swept over all the way to the right abdomen there. And the kidney is displaced inferiorly, and then the descending colon, which would be retroperitoneal, is displaced anteriorly. So this all supports a retroperitoneal origin of this mass, and certainly for smaller masses, it can be really helpful to kind of look and see which structures are displaced where, and try to infer what compartment they arise from as you form your differential. All right. So kicking off this case, we see the spleen is a little bit enlarged. Maybe that's relevant. Let's take a look. Some enlarged lymph nodes in the upper abdomen. And then we have this kind of fuzzy appearance of the kidneys where they almost have like this surrounding thickened soft tissue halo. The rectum is pretty thick too, and there's all those mesenteric lymph nodes, which I think will stick out a bit more on the coronal images. Let's pull those up. Here we go. So we see those halos surrounding the kidneys, kind of soft tissue rind-like thickening, that retroperitoneal adenopathy, that mesenteric adenopathy, thickening of the bladder wall, which might be involved as well, and then also thickening of the rectum, which was a new finding. So this is a example of perirenal lymphoma, and just kind of a different manifestation where you're seeing it mostly surrounding the kidneys rather than causing renal enlargement or infiltration of the parenchyma. And here we have another case of an unusual perirenal mass. So the kidney does look like it's partially obstructed. There's a delayed right nephrogram, and mild to moderate hydronephrosis. And there's also these perirenal lobulated masses that almost look a little bit like those plasmacytomas did earlier on, with this bulkier mass near the renal hilum. So certainly an unusual case and a complex case, and one that requires biopsy for definitive diagnosis, which was done with ultrasound. And this is a case of renal lymphoma. And so this patient came back about 1 month later. So let's take a look at what happened here. So really kind of that dramatic growth, much more expansion and displacement of that kidney just in a 1 month time period. So this does highlight how quickly these cases can change. And so if you're seeing a infiltrative soft tissue mass, notice how it's surrounding some of the vasculature, how there's not only that kind of what I guess you could think of as a primary component of the mass here, but these other kind of separate areas within the retroperitoneum. We don't have nodal disease as a primary feature to help us, but certainly if there's a high suspicion of renal lymphoma based on these findings, and just realize the importance of making that diagnosis on a timely basis and how quickly these patients can progress. All right, our next case here. So starting off with some splenic enlargement and a little infarct of the spleen. And here we have that rind-like thickening that we saw earlier in that case of renal lymphoma. This has a little bit more pronounced thickening and stranding, and we also have all of that retroperitoneal nodal involvement as well in the setting of splenomegaly. And this is a patient with a known diagnosis of lymphoma, but this is another example just to illustrate perirenal lymphoma, this time with that nodal disease to help benefit us in our diagnosis. All right, so for our next case here, the spleen is a little big with some hypoattenuating lesions, and now here we have that more typical appearance of renal lymphoma, which is commonly taught as having renal enlargement with diffused infiltration of the parenchyma, but hopefully you realize by now there's quite some variation in how it can present, but this one is presenting a little more classically for us. There's also some other manifestations of lymphoma with some nodal thickening of the retroperitoneum, and also all of this infiltration of the lower rectus abdominis musculature and inguinal lymph nodes. This is a case of follicular lymphomatosis. All right, so for this case, I think the question here for that right kidney is, do we think it's urothelial carcinoma or do we think it's lymphoma? And indeed, this is a tough one because we see a large portion of that upper pole looks like it's diffusely infiltrated by tumor, but we also have kind of all of this extrarenal lobulated soft tissue looking tumor as well. We have some lymph nodes in the retroperitoneum, and also all of the soft tissue in the retrocrural region, which would be unusual findings to see in the setting of urothelial carcinoma and much more common with lymphoma. There's also some infiltration of the adrenal gland, which could be seen in both. But I think this spread of soft tissue disease or nodal disease in multiple other territories and kind of that bulk of extrarenal tumor can help us to be confident in making this diagnosis, or at least suggest the diagnosis, which would then need to be confirmed by biopsy. But this is, again, renal lymphoma. This case has some important overlap with the preceding cases of renal lymphoma, but also some important differences. We are seeing a similar pattern of perirenal nodular soft tissue infiltration within the retroperitoneum. There is also some surrounding kind of upper abdominal nodal disease, which is encasing the vasculature. And so certainly at first glance, I think renal lymphoma would be in the differential, but there's another important element of this patient's history, which is that the patient had a history of breast cancer about 7 years prior, and this is just a routine staging examination. So these are all new findings, and certainly lymphoma was on the top of the list, but we have to keep in mind unusual patterns of metastases. And this patient had a particular form of breast cancer which can go to multiple sites in the abdomen and pelvis, including the retroperitoneum. And this is an example of perirenal and retroperitoneal metastases due to invasive lobular carcinoma. We can kick off with some examples of mimics in the retroperitoneum. This is one of the kind of more interesting and important mimics to keep in mind. So here we have this large retroperitoneal mass, and at first glance it's a little hard to tell exactly where it's coming from. I think the coronal helps to see that it's not coming from the kidney, even though it's kind of butting into the kidney a bit. It almost looks like it might be arising from the liver, but it's centered on the IVC. So the intrahepatic segment of the IVC is expanded with tumor, and then there's this component outside of the IVC as well. And the other important structure to add to your checklist is to find the adrenal gland. So here's that right adrenal gland, which looks relatively normal and uninvolved, although the lower margin is a little suspect. So this was biopsied with ultrasound and found to be in IVC leiomyosarcoma, and I'll show a couple more examples of that to get a sense of what that looks like. It's an important retroperitoneal mimic. For our next companion case here, we have another lobulated retroperitoneal mass, and we can go through our checklist. This time, it does look like that right adrenal gland is relatively spared, although the lower margin we kind of lose it a bit, but it doesn't look really centered on the adrenal gland. The right kidney also appears to be distinct from the mass, but the IVC, as we follow it up, looks like that's kind of primarily that forming the epicenter of the mass. And it has that kind of lobulated component along the posterior margin of it, and then it meets up and infiltrates into a portion of the lumen here. So this is just another example, biopsy-proven IVC leiomyosarcoma. Of course, when there is a number 2, there is a number 3 example. So we're going to show a third example of IVC leiomyosarcoma here, starting with really abnormal liver enhancement, which is due to occlusion of the renal veins and the IVC by expansive tumor. So this is Budd-Chiari. There's some thrombus extending into the right atrium as well. And then following that inferiorly, we find this rounded exophytic component of the IVC leiomyosarcoma, and then inferior to that, almost essentially a very decompressed and small caliber IVC. So here's what that looks like on coronal, where there's this bulky lobulated component of the mass just outside of the IVC lumen, which is coming up here. And then all of this, the wall is just diffusely infiltrated by tumor, which extends superiorly, taking out the renal veins as well into the intrahepatic segment of the IVC and all the way to the right atrium, resulting in, as I mentioned earlier, Budd-Chiari. All right, so for this case, we have, again, primarily what is a perirenal pattern of disease, where we have soft tissue thickening surrounding both kidneys. And let's get a better sense of what that looks like on coronal. Looks like there's a little bit of renal volume loss, maybe even some calyceal dilation, some urothelial thickening as well, but primarily that kind of perirenal rind with some kind of interspersed fat. Almost looks like it could be a so-called hairy kidney, but let's take a look at some other imaging that was done for this patient. So Well, let me ask, I guess if you're going to encounter this on a CT, what is one of the confirmatory things you might want to look for to help you make the diagnosis for the patient? So one of those things for this specific example is to look at long bone radiographs and to look at those typical characteristic medullary sclerotic lesions, which we have here and here in the humeral head, and also here in the distal femur, and kind of in the proximal tibia, which we don't really get much of, but definitely characteristic. And then the patient also had a bone scan where we're seeing those correlates as well. And this is a case of Erdheim-Chester disease, which is a non-Langerhans cell histiocytosis, which can cause infiltration in multiple organ systems, but is mostly characterized by perirenal manifestations and those characteristic bone lesions. All right, so our last case is an MRI, which is mostly just to prove that I also know how to look at MRIs after we did all those CT-based cases. And so here we have what looks like essentially replacement of a portion of the left kidney with this large cluster of cysts, but otherwise normal appearance of the rest of the kidney and normal appearance of the right kidney. And so I think the axial image in particular helps you to appreciate how it's essentially a cystic process replacing a portion of the cortex. This is a benign etiology called localized cystic renal disease and is diagnosed by seeing that kind of cluster of cysts in one kidney with the normal appearance of the other kidney. All right, so we have covered a lot of ground, including renal stones, infection and mimics, primary tumors, and other tumor or tumor-like conditions. Many of these cases are available here in DICOM format for you to review on my website. And I thank you very much for your attention, and I hope that you found this talk helpful.